Good afternoon. This is Dr. Charlie Smith. I'm the Regional Administrator for the Substance Abuse and Mental Health Services Administration here in the Denver office. Our apologies for starting a little bit late. We've had some technical difficulties, and actually our Principal Logistics Coordinator, who is the Central Rockies Addiction Technology Transfer Center, has been unable to actually kick off the call, so you get to hear my lovely voice. So we're starting off right now, and so I'm going to cover a little bit for the ATTC's slide deck, and then we'll move right into our guest speakers for today's conversation. So this is a quick slide on the Addiction Technology Transfer Center. There are 10 centers that are regionally located around the country, as well as we have 4 national addiction technology transfer centers, and they provide a host of valuable information and resources for the substance abuse, as well as healthcare providers across the regions as well as across the country. The University of Utah holds the Central Rockies Addiction Technology Transfer Center, who is actually helping to coordinate and host today's webinar. Next slide. We're going to see if this works. It does. So a couple housekeeping items. For all of you who have been able to join, please go ahead and mute your telephone as well as your computer screens throughout the duration of the webinar. It just makes for best sound quality. It's also best to use the call-in number on your phone rather than through the computer, but that is your choice. If you have any technical difficulties like we are experiencing, feel free to contact Shannon Christensen. That's her email address as well as telephone number. If you have questions throughout the webinar, feel free to use the chat screen, which is on the bottom right-hand side. And if time permits, we'll be able to address some questions during the webinar, but currently we do not anticipate that time will be that forthcoming. At the same time, we would be happy to respond to those questions via email after the webinar. The webinar is being recorded via a URL, which will be posted on the Central Rockies ATTC website after September 1st, 2015. There'll be a copy of today's PowerPoint presentation in the handout section of the webinar toolbar, which is on the right-hand side. You will see that there are 3 handouts in that section, including today's PowerPoints, as well as if you have any there are instructions on how to complete the post-webinar test to receive continuing education, as well as there is a survey that the ATTC will be sending out at the end of this webinar, which is for an evaluation of the overall webinar that's important for their clinical review with the SAMHSA funded grant that they have, which is called the GIPRA survey. So we appreciate you filling that out. So at this point, let me move on to the next slide, which is kind of kicking off today's conversation. First, we'll have Dr. Christina Mead, who is the Regional Pharmacy Consultant for the Health Resources and Services Administration. And I believe Christina, she'll speak later. So I think the next person who'll be actually going in is Kim Patton, who will be talking about opioid drug intervention and drug disposal strategies, and actually that's flip-flop. So Christina's going to do that piece, Kim's going to do some of the introduction. And then I think at this point I'm going to pass it over to Kim.
Great, thank you. Welcome everybody. Good morning or good afternoon. This is Dr. Kim Patton, and I'm with the Health Resources and Services Administration, or HRSA, and I'm really excited that you've joined us today for the Region 8 Public Health Learning Series entitled Strategies to Address Opioid and Prescription Drug Misuse. This is a 5-part webinar series brought to you, as you've heard, by a collaborative effort with the Central Rockies Addiction Technology Transfer Center and the Denver regional offices of the Health Resources and Services Administration, or HRSA, as well as the Substance Abuse and Mental Health Services Administration, or SAMHSA. And at this time, I'd like to thank and acknowledge my colleagues here with me today, Captain Christina Mead, who is the HRSA Regional Pharmacy Consultant, and you've already heard from him, Dr. Charles Smith, the SAMHSA Regional Administrator, for helping to make this series a success. The 3 goals of this 5-part learning series are to increase knowledge and practical skills related to safe clinical practice guidelines for prescription medications, the clinical treatment of addictive disorders, and the use of naloxone for opioid overdose. Today is our 5th and final presentation in the learning series, and this presentation will focus on opioid overdose intervention and drug disposal strategies. Today's presentations will address how to manage the increasing problem of opioid overdoses and the importance of drug disposal as a public health strategy. However, before we get started, as a reminder, if you want to ask questions, again, during the presentation, please use the chat feature at the bottom right hand of the screen, and time permitting, we'll answer questions, but likely you'll need to put those in the chat feature for later. And now let me introduce the speakers for this session. First, we'll hear about opioid overdose intervention from Lisa Rayville. She is the Executive Director at the Harm Reduction Action Center in Denver, Colorado. Next, Dr. Charles Smith, who you've already met, will discuss national and regional resources and the Opioid Overdose Toolkit. And finally, Captain Christina Mead, the HRSA Regional Pharmacy Consultant in Region 8, will discuss drug disposal strategies. Lisa, I'll hand it over to you.
Wonderful. Thank you so much for having me today. My name is Lisa Rayville. I'm the Executive Director of the Harm Reduction Action Center. We're Colorado's largest public health agency who works with people who inject drugs. While we do a lot of things, we're most notable for being the largest syringe exchange provider in the state of Colorado. However, as soon as we were able to start doing syringe access, we knew that we needed to do something to prevent people from dying of opioid overdoses. Next slide. So I don't think it's any secret that people are dying of overdoses nationally and internationally. It's the leading cause of death of accidental overdose in the United States. Recently, the Center for Disease Control and Prevention came out with a report talking about the heroin overdose deaths that have nearly quadrupled in the United States. And what I primarily see in Colorado is heroin as a primary drug of choice. We also are experiencing not only the national issue, but the local issues of people shifting from pharmaceutical drugs to heroin as well. Right now, Oxycontins are running 50 cents a milligram on the streets of Denver. So one 80 milligram pill is $40. $40 can keep you well on heroin for a good couple of days. So we're seeing the shift happening. Next slide. So this is just a snapshot of overdoses in Colorado right now. If stigma and shame worked with addiction, we wouldn't have this problem, right? Stigma and shame don't work. We've lost too many people. Dead addicts don't recover. So we want to be able to talk today specifically about something that can really work for people, which is access to naloxone. It is to be noted that overdose is the leading cause of death of homeless adults in Colorado, and that has been since 2012. Next slide. So I just wanted to talk about something that's happening internationally and that's coming up soon. This is something that you could be doing in your community. Every August 31st is International Overdose Awareness Day. It's a time that we talk about not only prevention of overdose, but also remembering those that we've lost. In 2013, we had Governor John Hickenlooper go ahead and make that Colorado Overdose Awareness Day. We were really excited when he was able to make that into a proclamation, and that's something that other states are starting to do just to get out more awareness. This year, August 31st is a Monday, so there will be some local efforts. Also, overdoseday.com are international efforts of folks in your community that are doing something to prevent and remember those that we've lost. I think this is just a really good opportunity that Hickenlooper put in there, that Overdose Awareness Day sends a strong message to current and former drug users that they are valued. Next slide. So I know we have a lot of clinicians on the phone today, and I just wanted to make sure that we're all on the same page when what we're talking about is opioids. I think we know that when somebody's overdosing from stimulants, the best thing you can do is call 911. However, today primarily we'll be talking about opioids and opioid overdoses. Next slide. And I think it's important as well to talk about kind of the signs and symptoms of an overdose. This is something that we talk about with folks in our community all the time, and these are the conversations that you can be having with people. I think one of the biggest issues that we see is sometimes people, the line between being really high and overdosing is very fine. So I think in the blue skin tinge, the body's very limp, face is pale, there can be throwing up, passing out. Most overdoses happen over several hours, so a lot of people do die overnight, and there is a gurgling, snoring noise that people say that you will never forget. It's also called the death rattle, so when people pass away overnight. So that you can see kind of just in the grid there of what really high looks like. And when we talk about, trying to assess if somebody, the difference between being really high and overdose is a sternum rub, if they're not, reacting to any pain, things that would make them very upset, like the cops are here, or I'm doing all your drugs, things like that. So if they don't wake up from that, obviously they're overdosing. Next slide. So naloxone is very magical. It's a prescription drug. It has gained national and international attention very recently. It's been used, obviously, by emergency departments and EMS for over 40 years. It's not addictive. It's not a scheduled drug. The only thing it can do is knock the opiates off the receptors for 30 to 60 minutes while you rescue breathe for someone and call 911. What the picture here is an injectable. That is a nice way that people can get that out. I also have a picture of the intranasal. But we really talk to folks because we know that we need to get that in the hands of not only drug users, but people who love opiate users. Not everybody is going to make it to an emergency department or have access and calling 911, unfortunately, because people are very afraid. So it's been really in the drug-using community since the mid-90s. We've had to pass some laws in Colorado to make it so, and I know Utah is the same. Other states around us, we want to be very supportive to be able to get naloxone into the hands of people that want it the most. Next slide. So this is what the intranasal looks like. For those of you out there about, just kind of what would work for folks, prescribe to prevent .org is really important for not only physicians but also pharmacists as well. They have videos, they have how you can bill for it. Medicaid covers naloxone in the state of Colorado. They're now starting to cover the atomizers for the intranasal. On this prescribe to prevent.org, pharmacists can know where to order it from. And so it's been a really nice opportunity for folks to be able to get access out there to those that need it the most. Right now we have not only our emergency personnel carrying naloxone, but Denver Police Department and Boulder Police Department now have intranasal naloxone. The state of North Carolina, Georgia, New York, their first responders, including fire and law enforcement, are also carrying naloxone, especially in the rural areas where they come up. Oftentimes they're the first one on the scene before the paramedics get there. Next slide. So we talk about kind of the risks for overdose and how to prevent that as well. And there's 4 major reasons that people end up overdosing. The first one is the change in the quality of the opioid. Heroin purity in Denver is anywhere between 2 and 57% at all times on the streets of Denver. There's no better business bureau for dealers, as you can imagine. So one of the issues that people have is they never know what they're getting or what they're injecting. So we tell people kind of a strategy for that if you're working with injectors, kind of knowing your dealer and doing a tester shot, which means just doing a little bit to see. You can always do more, you can't do less. We also have another risk factor is changes in tolerance. Any sort of period of abstinence after hospital, rehab, jail, prison, or any sort of illness or compromised immune system, there's a higher risk of overdosing and dying from that. So we do talk to people about making sure that they are only doing just a little bit to make sure that their body can handle that if they are going to use again. The third one is mixing. You know, it sounds like a good idea when you're drinking everything. So we want to make sure that people aren't using pharmaceuticals and drinking at the same time. If you have somebody that does both and you're not sure what to do, we always say do your opioid first, only because that can kill you all by itself. You don't need the alcohol for that. So that's kind of a realistic message that we talk about. In a very magical world, there would be no drugs, but we live here, and we want to keep people safe and alive. And then the fourth issue, obviously, is using alone. Most overdoses are witnessed. Only a small percentage are kind of the happening quickly or the needle in the arm that you kind of hear about in the movies. And so we talk to folks about making sure that they try not to use alone, plan to leave the door unlocked, or call someone they trust. Next slide. So the CDC has been busy this year because they've also come out with another MMWR report, and this one is about community-based naloxone programs. So they've actually had access since the mid-90s to giving naloxone to users, as most overdoses are witnessed, and then we have been trying to make sure that people around people at risk of an overdose can have access as well. We've been able to train over 500 folks and had 215 lives saved just through our program. In 2012, our doc was able to prescribe to opioid users. However, if you're in the midst of an opioid overdose, it's very difficult to naloxone yourself. So we wanted to make sure people around people at risk had access to that. And so that's mothers, homeless service providers, me, because oftentimes we're in the best place for folks experiencing an overdose to make sure to save their lives. And what's been great is the community-based organizations have really been coming out of the woodwork, and there's been, since 2010, a 183% increase in organizations. Community-based organizations and clinicians are very trusted, and so we want to make sure that people, if they're using drugs or know somebody using drugs, we want to make sure that they have access to naloxone. Next slide. So unfortunately, and you may have heard this as well, as when people don't have access to naloxone, a lot of the response myths have been other ways of getting people to stay alive. There's a lot of trauma in the drug-using community in general because a lot of people have witnessed overdoses, and unfortunately a lot of people have died due to overdose. So some of the response myths you may hear of are salt water, Suboxone. A lot of people think that with the naloxone in there will help, and not so much. Ice on the body, cold shower, cocaine, milk, burning the skin, punching, slapping. Those for years and years, that's all people have been able to use as, you know, kind of a community of trying to keep people alive. We know naloxone works, and that's why we want to make sure that we have access to that. We do encourage folks to call 911 so that we know the shortest acting opioid is probably 4 hours. We know naloxone is only 30 to 60 minutes, so we know that this person really should go to the emergency department to kind of be babysat for the rest of the day. Next slide. And so this is just kind of what it looks like to administer naloxone, or, you know, to come up on an overdose, and to what that looks like. Are you all right? Are you okay? Pain stimulus, that's the sternum rub, that's the I'm going to do your drugs or the cops are here. If no response, we encourage people to call 911. We do rescue breathing, so we often do one breath every 5 to 7 seconds. Before you even do the naloxone, you want to get some breath on board. Make sure you breathe for yourself. Do naloxone and continue rescue breathing. Naloxone usually works, the first dose usually works within 3 minutes. If you have to use 2 doses and nothing's happened after 5 minutes, then this is not an opioid overdose, this is something else. So we know that naloxone only knocks the opioid off the receptor. It doesn't do any more than that. Next slide. So the training, it can look, you know, whatever your community is comfortable in doing and what it can look like. So it can be a full hour to answer all sorts of questions for people, and being in a group model to anywhere from 10 minutes that can happen with a pharmacist. Research is showing that training, you know, short trainings are quite adequate for laypersons. On that prescribetoprevent.org website, there's a ton of videos people can use too, talking about, you know, chronic pain patients versus people who inject, versus using intranasal, using injectable, that sort of thing. So they've really done the work for us on that, so there's no need to reinvent the wheel. With standing orders, it can be done by community-based organizations or pharmacists. And then you want to include the discussion of the risk factors, the recognition, because we want to be able to prevent an overdose as well. Naloxone is for the treatment, but we want to make sure that somebody doesn't even have to overdose. Calling 911, rescue breathing, and administration of the naloxone. Next slide. So in the state of Colorado and in Utah as well, we have a few laws where we need to make sure that we reduce the harms associated with overdose in our communities. A lot of times for law enforcement law enforcement implements the law, so sometimes we have to change the laws to protect those in our community. The first one we passed was in 2012. It's the 911 Good Samaritan Law. If Kim and I are hanging out doing drugs, and she overdoses, and in good faith I call 911, she and I don't get charged for small amounts of drugs. That's really important because a lot of times people have been very afraid and have ran, and so we want to make sure to get people, cops don't want to come up on dead bodies, and people want to make sure to have access. So Utah has this law as well, along with Colorado, and probably over about 20 states in the United States. So I know there's a big national movement to make that happen. Next slide. And then also Colorado and Utah had to pass the third parties. We just had to make sure for prescribers in general. It's a little different when, so prescribers can prescribe to opioid users. However, if you're in the midst of an opioid overdose, it's very difficult to use naloxone on yourself. So this allows for other folks around people who love opiate users to have access. I don't know why I said 21 lives. It's 215 lives. I apologize on that part, but especially what's been really interesting as well, and we were talking about that earlier, is there can be some provider hesitation for prescribing naloxone for a variety of reasons. We do know that opiate users do not want to be in withdrawal, so there have been some there's been at least one study done of folks that are not using more of the opioid because they know naloxone exists. No opiate user ever wants to be in withdrawal. And so to encourage prescribers in our community, we went to COPIC, which is the Colorado Physicians Insurance. They have been at the table for all of the statewide legislation, and so we specifically went to them to have them be supportive in their newsletter, and in May they released a statement encouraging physicians, physician assistants, advanced practice nurses, and pharmacists to understand their important role in providing this to at-risk individuals, their families, or those likely to encounter such persons. So that was basically COPIC raising their harm reduction freak flag, so we were really excited about that. Next slide. So because we've had some provider hesitation since the 2013 law for third-party naloxone, we went ahead and passed another law this year. In 2015, it was standing orders for expansion to naloxone. All 100 state legislators voted in support of it, and when's the last time they agreed on anything? So this allows for physicians to write a prescriptive order, authority to write an order for a medication that could be dispensed by designated individuals, such as harm reduction organizations and pharmacies. So anybody that reduces the harms associated with drugs in the state of Colorado is a harm reduction organization. I am working under, my agency is working under our prescriber, because that means that the prescriber doesn't have to be on site, because while we've trained over 500 people in the last 3 years, I've had over 3,000 requests for it, but not everyone could make it at the exact time my prescriber was there, and there's a definite need in the community. Also, a lot of people won't access my agency if they don't inject drugs, and so we want to make sure that pharmacies have access as well. And so something that's really great that's happened in a couple of other states out east, but is happening in the state of Colorado, that can happen in a state near you, is the Chief Medical Officer, Dr. Larry Wolk, with the Colorado Department of Public Health and Environment, has stated that if anyone needs a prescribing doc to work, to do the standing orders, to work underneath them, he's the guy. So all of these pharmacies that you see here are working under Dr. Larry Wolk with the State Health Department. He's also made it so he's putting it in the job description so that anyone else after that as a physician will be able to do the same thing. So that really expanded access to naloxone to every corner of our state. So these are the pharmacies we know about right now, primarily in the metro Denver area, but we are trying to get it into the rural areas as well. We want to make sure if people want access, they can get that. And so these pharmacies today, you can walk in and get access to naloxone and leave with 2 doses. Next slide. So here's the information about Dr. Larry Wolk. And kind of why standing orders is working and underneath his license. Standing orders are also working in some of the hospitals. Denver Health and Hospital in Denver is doing something extremely innovative that's happening only, as far as I know, in a couple other hospitals out east. This could be something that could happen in your community. Is anyone who comes into the emergency department on observation of an overdose, right? So we've called, they're overdosing, we've called 911, they go to the emergency department, are being discharged with a prescription to naloxone that they can pick up in the pharmacy right there. because that's huge. Because most people that are going to the emergency department on observation of an overdose are using pharmaceuticals, and so if they don't know, this could be a first-time thing for them. They didn't really know how this happened. So a lot of times they can get the access to naloxone, and we really feel like that's huge, and we want to make that the Colorado standard so folks can have access in our community out of every hospital. And so the standing orders can not only work in the emergency department, but if once it's put on the formulary of the hospital, all of the prescribing docs within that hospital can prescribe to naloxone. So we want to see it at some point, and not only just in the emergency department, but anytime someone's prescribing an opioid, we want to be able to suggest that they have a pharmaceutical, that they have access to naloxone. And so I think that's incredibly important to make sure that the pharmacists are really part of these healthcare centers and that they're encouraging that as well. Next slide. And so this is my agency across the street from the Colorado State Capitol, right where I'm supposed to be. This is my email just in case you have any follow-up questions, issues, or concerns. Thank you for your time.
Thank you, Lisa. That was a great summation of, I think, a lot of the approaches within Colorado concerning naloxone, and also a great example of where many of our other communities, while not in Colorado or not in Utah, can really take advantage of some of our local efforts that have actually saved lives. The piece that I would actually add is that the Veterans Administration has actually taken a very aggressive stance, and actually under the leadership of Dr. Chris Stock, who was actually one of our presenters during our first webinar, to make available naloxone for free for all veterans who are currently identified as opioid users. And it's actually being now discussed as a potential pilot for other VA hospitals as well as Indian Health Services. So this is Charlie Smith. I just wanted to spend a couple minutes prior to Dr. Christina Meath, who's going to talk a little bit about drug disposal strategies, but really to illuminate what Lisa had mentioned, in that SAMHSA, the Substance Abuse and Mental Health Services Administration, has a very valuable toolkit, which is known as the Opioid Overdose Toolkit. It is available free of charge on SAMHSA's website, which is www.samhsa.gov. And the toolkit is an expansive compendium of research as well as very practical approaches to address opioid overdose. There are free resources within the toolkit for individuals, for family members, for communities, and especially for clinicians. The toolkit provides educational material as well as very practical and plain language about the steps to take to prevent opioid overdose and how to treat those overdoses. And it really kind of builds upon, in a more generic form, the specific examples that Lisa had spoken about, yet examples that can be used in states and communities where there may not be those laws, and the flexibility within the communities to support naloxone's availability, but to provide those general approaches to really bottom line save lives. And so I strongly encourage you to check out, make available to all of your clinicians and all of your staff and colleagues this toolkit so everyone's actually speaking the same language. SAMHSA as an agency has been working very closely with the Office of the National Drug Control Policy within the White House, as well as with the CDC, the FDA, HRSA, and many other federal agencies to really emphasize the issue about opioid overdose. HRSA and SAMHSA, as well as other HHS agencies, are pushing very strongly with regard to an opioid drug prevention program being proposed in the 2016 federal budget, which is, again, to help states and communities reduce the number of opioid overdose related deaths, and we're hopeful that that proposal for funding will help catapult even more initiatives, much like Lisa had described. In addition, SAMHSA, as a federal agency, provides block grant dollars to all states, and a portion of those block grant dollars are to support states addressing substance abuse treatment, specifically opioid treatment, as well as recovery services. It's an opportunity for states to examine how those block grant dollars can be used to support naloxone, and actually there's a great encouragement within SAMHSA that states actually use those block grant dollars to actually fund naloxone within their communities. And I encourage you to kind of reach out to your state offices of substance abuse and or behavioral health. Each state has its own definition. They are the holders, the managers, administrators of those block grant dollars. In addition, SAMHSA has a host of resources, and we've spoken to some of these resources on previous webinars, that are there to support communities and specifically families, patients, and clinicians like most of you. Those services and resources are available through SAMHSA's website. You can also tap any one of the regional administrators. There are 10 regional administrators across the country. I serve for the region of Colorado, which is, well, actually the region of Region 8, which is Colorado, Montana, North Dakota, South Dakota, Wyoming, and Utah. So for any of you on the call who need additional resources or specific guidance to the issues of opioid overdose, opioid treatment, as well as some prevention programs that we are doing, you are always welcome to contact this office here in Region 8. Specifically, SAMHSA supports states that have a state opioid treatment authority, otherwise known as a SOTA, as well as the opioid treatment programs within those states. And you can easily find a list of all those opioid treatment programs and where they're certified by actually going to the SAMHSA treatment website, which is actually a treatment locator on the SAMHSA website that will identify all those opioid treatment programs, both individual, small group practice, large group practice, as well as hospitals, as well as a list of those HRSA-funded programs that are providing substance abuse treatment across the country. In addition, SAMHSA has been promoting with ONDCP, the Office of National Drug Control Policy, a new guideline, federal guideline concerning opioid treatment programs. Again, it provides a full range of services that those opioid treatment programs provide, such as medication-assisted treatment, which we spoke about at our last webinar, as well as provides a number of direct resources that are dealing with recovery-oriented care. In addition, SAMHSA funds a number of educational programs for clinicians. Most notably, we fund the Providers Clinical Support System and their learning communities for clinicians who are using opioids in their practice to manage pain, as well as specifically clinicians who are using buprenorphine for the treatment of opioid addiction. The clinical support system available can be reached by going to the SAMHSA website, and it's actually SAMHSA's efforts to coordinate with the University of San Francisco to provide this national resource for clinicians doing pain therapy as well as substance abuse treatment. Finally, SAMHSA has a number of different toolkits and treatment improvement protocols, as well as consumer education resources that are available for your work with patients and family members and consumers, as well as there's a major push within the federal government to really stimulate the growth of integrated care across our primary care, physical health, as well as behavioral health care systems. And the Center for Integrated Health Solutions is a prime site which is funded by both HRSA, the Health Resources and Services Administration, and SAMHSA to promote integrated healthcare networks so that we're able to provide one-stop shopping for behavioral health services as well as physical health care for the clients who need them. And we know that those individuals who are struggling with opioid addiction and other substance issues have major physical health care conditions and vice versa. So I strongly encourage you, if anything, this is a big pitch, take advantage of SAMHSA's resources, take advantage of the federal government's resources. They are there to assist you in providing the best care possible. And if there are questions, even post this webinar series, and I know we're wrapping up today, you have a variety of supports not only in the speakers, but also in the agencies that we work for. So at this point, I'm going to pass the baton to Dr. Christina Mead, who will talk about drug disposal strategies.
Thank you, Dr. Smith, and good afternoon, everyone. So we talked about the overdose potential, and the need for disposal is essential. I know as clinicians, I'm sure many, if not all of you, have received the question from your patients regarding, hey, I've got a bunch of medicine at home, what do I do with it? And I'm sure you as clinicians are saying either you have suggestions or you're not certain. So over the next few minutes, I have some 3 different goals that I'd like to establish, and I'd like to convey the essential need for an unwanted drug disposal program. So today my goal is to help you understand the communities and partnerships that play a role in drug disposal. And during this session, I'd like to ask you to consider what your role is as a clinician as you counsel and educate and provide care to your patients. I'd also like to provide you with contacts, both at the federal and state level, to help you engage with your community infrastructure for disposal. Next slide, please. So I would like to present 3 key disposal strategy areas today. By no means is this exhaustive, but these are things I'd like for you to think about, and they are the essential public health elements of drug disposal for patients and healthcare systems. I'd like to very briefly go over the nutshell version of the new DEA guidelines and the healthcare provider role in disposal. And lastly, I'd like to talk about federal, state, and community drug disposal partners and how to connect with them. Next slide. Before we get to all that, though, I'd like to give you just a little bit of background about how all of this fits together. And if you've been with us for the full 5 sessions, you've heard this a couple of times, but I think it's important to really understand the framework kind of from the national level as it trickles to the states and how they choose to pass laws and deal with this issue of prescription drug abuse. So let me start with the White House Office of National Drug Control Policy. They have outlined a prescription drug abuse prevention plan that includes action in 4 major areas to reduce prescription drug abuse. And those areas are education, monitoring, enforcement, and proper medication disposal. Next slide, please. So within the disposal framework, various federal agencies have distinct roles and responsibilities. I think Dr. Smith very aptly outlined exactly what some of those are. I have just provided you with some very brief information on these next few slides, but these slides are more meant to show you who at the federal level, which agencies are involved, and I think that you'll find them pretty diverse because there are so many facets to this problem that we need to have interagency and interdepartmental collaboration. So let's look at the Environmental Protection Agency. They are responsible for disposal messaging from the environmental impact standpoint. The Food and Drug Administration is responsible for disposal messaging as well, but from the consumer safety aspects. Health Resources and Services Administration is responsible for the integration of public health and primary care for the programs that we support. In addition, we provide provider education, grants, and behavioral health services on top of the primary care services that we provide. Next slide, please. The Substance Abuse and Mental Health Services Administration is responsible for providing integration of behavioral health and primary care, in addition to providing the state-based block grants that Dr. Smith had described earlier. And then, of course, the Drug Enforcement Administration. They're responsible for diversion and disposal guidelines and enforcement. And we'll get to that in a little bit as well. Next slide, please. So first, let's talk about the public health implications and how the utilization of drug disposal outlets positively affect public health. According to the National Center for Health Statistics, Americans use more prescription drugs than a decade ago. In fact, current statistics show that 1 out of 10 people are prescribed at least 5 or more medications on a regular basis. Next slide, please. So the increased availability of prescription drugs is directly contributing to the more than 7 million people who abuse prescription medications. The latest national survey on drug use and health shows that over 70% of people who abuse prescription pain relievers got them from friends or relatives, while only 5% get them from a drug dealer or from the internet. And I'm talking about prescription drugs as well. Next slide, please. An additional public health consideration is the poison hazard of available prescription drugs. Unused prescription drugs pose a threat to both children and adults if left unsecured. I think that anecdotally we've heard about these, what they call Skittles parties. We know that high school and college kids have taken, I guess there's a new game where they take whatever medication they find in grandma's cabinet, take a handful of it and see what happens. These aren't necessarily narcotics or controlled substances, but just prescription drugs in general. And what we know from the CDC National Vital Statistics System is that poisoning is the leading cause of injury death in the United States. Drugs, both pharmaceutical and illicit, cause the vast majority of those poisonings. So over lead and chemical exposure, the medications people are using are the major cause of poisoning. Next slide. And then the last public health consideration I'd like for you guys to think about is that on the environment. Recent studies have detected trace amounts of many common prescription drugs in drinking water. These drugs are difficult to filter with our water treatment plants. They tend to be tiny in molecular size, and the drugs are entering the water system likely by 2 mechanisms: after normal expulsion from the body, but also by people flushing unused or expired medications down the toilet. Next slide, please. So you might be asking yourself, where do you find information on drug disposal? What are the guidelines? How is it supposed to be done? On September 9th, just recently, of 2014, the DEA published the Disposal of Controlled Substances Final Rule. It's been published in the Federal Register, and I've left some links there for where you can find it. The final rule became effective on October 9th, 2014, and I'm certain if you're a pharmacist you know this already, but I'm speaking to clinicians as a whole. This was a new piece of guidance, and there were some changes within that guidance. Next slide, please. So the 3 main subparts of the final rule revolve around these 3 things: the disposal of controlled substances by registrants. If you're a registrant, you know who you are. The disposal of controlled substances collected from ultimate users and other non-registrants. If you're not a registrant, the definition of terms is very clearly outlined within the guidance. And then lastly, the DEA defines the process for destruction of controlled substances. Now, if you're a pharmacist or one of the registrants able to collect medications, this is important information for you. In the past, law enforcement has been the major partner for DEA to set up disposal programs on a permanent basis within the states that put together that type of framework. Next slide, please. The final rule and the complete guidelines, if you're interested in viewing them, can be accessed on this website. In addition, the Drug Enforcement Administration has also put together a webinar explaining the final rule from a community who has implemented it very well based on some of the new guidances that they've outlined for proper disposal. And I think you would find that very helpful. So this brings me to something that's very important. The DEA has teamed up with states, law enforcement, and communities in a very collaborative way to host and support National Drug Take-Back Days. Now, these DEA-sponsored events aim to provide safe, convenient, and responsible means of disposing prescription drugs, while also educating the general public or the end users about the potential for abuse of medications. The next Drug Take-Back Day was just very recently announced, and it's going to be September 26th across the nation, with the exception of 2 states. So if you check the DEA website that I've provided there on or after September 1st, you'll be able to see what date the DEA will be hosting the event in your state, what time, and where. And I think that this is very important information for you as clinicians to convey to your patients if it's something that they're asking about. Next slide, please. So this slide is meant to illustrate just how much drug is collected during these events. So during the last National Drug Take-Back Day on September 27th of 2014, over 300 tons of unwanted medication was collected in one day. And you can see from this slide how many pounds were collected in each state. I find this slide to be incredibly impactful. That's a lot of drug to dispose of. And so the good news in this slide is that it's 300 tons of drug that people don't have access to who otherwise might. Next slide, please. So let's just talk a little bit about the federal and state points of contact and messaging for drug disposal in your state. As I talked about, the Drug Enforcement Administration is responsible for the guidelines and the legal procedures for getting rid of medications, but they also have on their website public disposal locations that are available through law enforcement permanently. They have always historically partnered with law enforcement quite well, and some states have permanent sites in place. The Food and Drug Administration has disposal information for consumers. They also have information on their website about how to make the drug non-retrievable. So if you do not live in a place where there is a site available or work in a healthcare facility where you have a drop box, it is possible to make for the consumer or the end user to make the drug irretrievable, and the FDA talks about how to do that. Next slide, please. The Environmental Protection Agency has a page dedicated to proper disposal and protection of our waterways. But most importantly, and I left this for last, your state departments of health are probably your most important contact for information about disposal. Many states have established a disposal process that is permanent, or they're in the process of doing so. And often, either your local health department has partnered with law enforcement outlets or healthcare facilities to message and collect these medications as a mechanism for getting these unused, unwanted drugs out of the hands of people who just don't need them anymore. Next slide, please. So the next 2 slides are just additional links and resources for where to get information about the National Framework on Prescription Drug Abuse, statistics for overdose and poisoning. The American Public Health Association has a bunch of information about prescription drug abuse as well. Next slide. And I have included more website links for the Drug Enforcement Administration and the National Association of Boards of Pharmacy. So with that, this concludes my presentation. I appreciate everyone who has attended this session. And with that, I'll turn it over to Dr. Kim Patton. Thank you. Thanks, everyone. I realize we're about out of time, but I do want to thank our speakers for today. Lisa Rayville, Dr. Smith, and Dr. Mead. That was excellent information. Just as a reminder for the participants, you can access the PowerPoint presentation as well as the continuing education information in the handout section on your webinar toolbar. The continuing education information will also be available on the Central Rockies ATTC website under continuing education. Lastly, this series of webinars has been recorded and will be available for viewing as well as continuing education credit as of September 1st, 2015. I'd also like to remind people that there is yet another link for the Government Performance and Results Act, or GPRA, in the webinar section of your toolbar. The purpose of the GPRA evaluation is to assess how the Central Rockies ATTC sponsored events meet your needs. First, you'll be asked to participate in a follow-up survey in 30 days, and then you'll be directed to evaluate the 5-part webinar series. Your participation would be greatly appreciated, but it is completely voluntary, and your responses are confidential. With that, this session and the learning series are concluded. Thank you again for joining us.